Afternoon, folks. This is a brief summary of a session I used to run called Critical Approaches to ADHD Culture Formulation and Intervention. In this, I will be providing a critique of the literature on ADHD. This is not meant as a balanced lecture. It is meant to serve a balancing function, and that's because the literature practice is so skewed and steeped in the medical model. In fact, it's so normalized, it's almost antisocial to raise these critiques, but it's important that you understand them and understand some of the consequences, and then form your own views about where this sits and your own relationship to the social construct that is ADHD. So I've asked you to complete a quiz before doing this. If you could complete it, and for every answer it's either true or false. There's none of your psychotherapeutic both and here. This is hard science. Answer each question, myth or reality, true or false, and then do it again at the end of this lecture. So I'm going to talk a bit about the history of where stimulants came from, because you can't think about the history of ADHD without thinking about the history of stimulants. And does anybody know the most popular brand of stimulant used in ADHD? Let me listen. Oh yes, at the back I can hear someone said Ritalin. Ritalin was actually named after this woman here called Rita. It was originally named Ritalin, named after the wife of Senor Panizon. Now, Senor Panizon was a researcher for Ciba Geigy in the 40s and 50s, and he synthesized this new stimulant, methylphenidate. And this was back in the days where if you weren't sure the effects of something, you'd go home and try it on your spouse. And that's what Senor Panizon did. He went home, he gave it some methylphenidate to Rita, and what she reported was that it really helped her tennis. So there we go, the ethics of medical research in the 40s and 50s. But it's had a major impact on the game. Bradley in 1937 really triggered the use of stimulants. He was using benzodrine on children in public care, and the reason why I was using benzodrine, that he was taking brain imaging slides of the children, and what he found was that a side effect of the brain imaging was that it caused nausea and headaches when draining the cerebrospinal fluid. And so to help with that, he gave them benzodrine. And there was no change in terms of side effects, but half the group of children had spectacular improvement in school performance. He reported this. What wasn't reported, the fact that he was doing this on children in care with limited kind of consent, but ethics, I suppose, maybe were different then. But that's how Bradley came across this idea of what were referred to as maths pills, this benzodrine helping performance in school. But this created limited professional interest. Then in the 50s, after Ritalin was patented by Ciba Geigy, there was big marketing at asylums. Here we can have it. You can bring patients out of the corner with Ritalin. But then inevitably consumer capitalism wants to expand markets. So in the late 50s and early 60s, as asylums closed, it became marketed at more general population to solve everyday problems. If chronic fatigue and maldepression make simple tasks seem big, Ritalin relieves chronic fatigue that depresses and maldepression that fatigues. Looking at the photos, looks like Ritalin's being marketed as a solution to patriarchy. But being more serious, if you think it's quite interesting, now it's being used for people that are overactive. Back then it was used for people with chronic fatigue. Isn't this interesting? However, we can't just think about the marketing of drug companies. We need to think about the wider social context about how ADHD developed in the 60s and 70s. In 1957, the Soviet launch of Sputnik suggested they were way ahead in the arms race than the Americans realised, and this convinced US policymakers that the education system was broken, and they brought in the National Defence Education Act in 1958 with a focus on technical subjects, but also, and here's the big issue guidance counsellors to identify children not meeting expectations but appeared intelligent. So the idea is, let's pick out the intelligent kids that aren't doing so well and let's see what we can do to change that. Meanwhile, in terms of psychiatric research, the focus was on severe hyperactivity leading to hospitalisation, very different from the group of kids that the National Defence Education Act was thinking about focusing on. Then in 1957, Laufer coined the phrase hyperkinetic impulse disorder and suggests it was a common condition found in most classrooms and recommends drug treatments. Interestingly, Laufer was based at that same Bradley home where they'd used Benzedrine on children in care. However, Laufer's suggestion wasn't really taken up by the profession, and this idea of a hyperactivity and impulse disorder remained at the fringes. You know, as time moves on, Ritalin started being marketed as medication for the whole family, for the chronically fatigued, the convalescent, the apathetic, the depressed older patient, the postpartum patient, the oversedated, and to use the old phrase, the kind of retarded child. So here we have, it was a panacea, well, Ritalin was the panacea for all ills. And in terms of creating markets, Ciba-Geigy really invented direct-to-patient marketing. And the influence of this can't be underestimated. And then they funded parent groups to campaign for clinics, i.e. medication, obviously paid for by the medication companies. That still happens today, by the way. CHAD, the major ADHD group in America that campaigns for clinics or, you know, increase access to medication, is funded by the major drug companies. But they also produced a very famous film called The Hyperactive Child, starting to get into the published consciousness that there was this idea of the hyperactive child. But then interestingly, in the 70s, the FDA actually started restricting this direct to patient marketing that Ciba-Geigy had modelled. Then in the 70s, the primary focus shifts from activity to inattention. This was quite shrewd because it broadened the potential group of kids we were thinking about. So the patient group moved beyond the disruptive and included more females. 70s and the 80s saw gradual increases in stimulant prescribing, and there we had it. 1987, so good they named it thrice. ADHD appears in the DSM Bible. However, the UK was more influenced by the stricter approach of ICD-10, and ADHD and stimulants, you know, having kind of less impact initially in the UK, but then a very small number of senior researchers really kind of do publish a lot of papers, really promote it, and it starts to take hold. And then we have DSM-5 in 2013 that really lowered the threshold from significantly impairing functioning to interferes with, therefore broadening the group and meaning more cis females will be included in the group labelled ADHD. Sorry, you can read that. This is a poem from 1700 describing a hyperactive child. That you see this, I'm just holding it up, there's this very shiny leaflet from a drug company that suggests this is a key part of the history of ADHD and other myths. But why are we meeting? Because really, the prescribing of Ritalin has expanded at a scale that there's been no public agreement about, but the increases are huge, and we want to decide as a country, do we want to move into a place that's like America, where 1 in 4 children in the classroom are on stimulant medication? Is that what we want for our schools? Is that what we want for our children? This lecture is not anti-medication or saying that medication is bad or anything like that. It's not anti-ADHD, but it's saying, what is the scope? Who do we want to include in this medicalisation and medicating of children? At the CQC inquiry, here we have a quote from The Independent. The use of ADHD drugs soars by more than 50% in 6 years. This was from the CQC. What's interesting is that's the figure for 07 to 012, but actually the figures from 96 to 2007 show a 6,900% increase in prescribing of ADHD medication. So why has there been an outbreak of diagnosis and prescribing around ADHD? Has there been a dramatic rise of incidence of mental disorder amongst children in the noughties and the 90s? Was there some crisis in kind of child mental health that exploded the numbers? Or have our expectations of children or schools changed? Why is it more a problem for white working class boys? Is it their brains, their genes, their parents, the schools, or the health services which are to blame? Or is blame part of the problem? And is this the future of CAMS? Now let's start off with the problems of diagnosis. The symptoms present in the general population. What I would suggest you go away and look through the list of symptoms in one of the standard textbooks of ADHD and put a circle around every one that applies to you. And I think when I do this in the room, a significant minority or most apply to most of the group. Also, whether one core symptoms are considered deviant is dependent on cultural context. We know that American researchers of ADHD, when they went to Mexico, rated much higher the prevalence of ADHD compared to Mexican researchers. And that's because American researchers have higher expectations of classroom behaviour than Mexican researchers. When those same American researchers went to China, they identified prevalence in a classroom as much lower than the local Chinese researchers. And that's because Chinese researchers' expectation of classroom behaviour is kind of much higher. So there, in a nice little experiment, I can send you the reference. It was shown how what is acceptable and unacceptable classroom behaviour linked with ADHD type behaviours is part of a cultural context. But it's important to know that there are no standardised tests, no specific brain functioning tests. Diagnosis is via medical history and subjective observation in class. I'll say a bit more about that subjective observation in class. But that is the situation, and that's not some radical view. That comes from the NICE guidance. As they say, the diagnosis of ADHD does not imply a medical or neurological cause. There are no biological tests for ADHD. So the first question is a myth. And I said it was subjective, the rating of classroom behaviour. Here's the most standard one that they use, the Connors rating scale. If you talk to teachers about filling these in, it's really interesting because, first of all, they're generally not filled in by the classroom teacher, but by the SENCO. And how does the SENCO know how the child is doing? Because the classroom teacher has a word. If you've got a newly qualified classroom teacher that's struggling with behaviour management, maybe they'll contact the SENCO more. You've got a more experienced teacher, maybe they'll contact the SENCO less. And it could be that one or two numbers on a couple of questions could be all the difference between hitting threshold and not. So when is the form filled in? If the form is filled in at the end of term, maybe the child is tired, maybe there's less structure at the end of the term, which triggers the child's behaviour, maybe they would score higher. If it's at the start of the week or the end of the week, speak to SENCOs and they will tell you these numbers become problematic when you look at reliability of responses. But there we go. This is the Connors rating scale. And actually, you look at the father of this scale and what does he say? He says, I was always suspicious that the high rates of diagnosis and prescription for ADHD came about because researchers based their figures on reports from parents who in turn based their beliefs on teachers or doctors with no credible evidence. And yeah, he's become more of a skeptic, old Mr. Connor. So there you go. So next I want to talk about ADHD as a shoddy construct. Problems with inattention, impulsivity and overactivity rarely present on their own. Look at the levels of comorbidity. 30 to 60% conduct disorders, 30 to 90% learning disorders, there's a range. 18 to 60% mood disorders, 25 to 43% anxiety disorders. In fact, as Furman, who's a paediatrician, says, significant overlap to this extent demonstrates extensive diagnostic confusion. It's not that all these kids with other problems have got ADHD, it's your whole diagnostic system is flawed. If you have lots of comorbidity, that raises a question about your diagnostic system, because diagnostic systems should be subject to Occam's razor. That's where they're simplified, where most people have at most one diagnosis. That's not the case in child psychiatry. So I'm just going to simplify it here, but it's a bit like thinking about the group of kids with ADHD, some might have learning problems, some might have conduct problems, some might have a history of trauma. And depending on those comorbid problems, that could be the context in which impulsivity and overactivity arises. And the diagram should be more complicated than that, because you'll have some kids that are seen as ADHD that might have all four of those comorbid difficulties. So why look at ADHD as a single category, as this group has few commonalities? This is the thing, you speak to child psychiatrists and you talk about interventions for ADHD and they say, oh, how can you have an intervention for ADHD when you're talking about psychological work? Because the group is so varied, from those in mainstream to those in highly specialised schools or not able to be safe in the community. And why isolate attention, activity and impulsivity from other difficulties? Are they a natural kind? And multiple difficulties, why prioritise attention and overactivity for classificatory purposes? Maybe other contexts are much more salient. More significantly, there are few neuroanatomical and neuropsychological reasons for viewing these functions, i.e. Attention, activity and impulsivity, for viewing them kind of separate from other cognitive functions. You know, there's a question about, do we view them together because they're the ones that are susceptible to mediation by stimulant drugs? Next, we have a major conceptual problem. What causes attentional overactivity and impulsivity problems? ADHD. How do we work out if they've got ADHD? Oh, the child has attentional overactivity and impulsivity problems. It feels like we're getting a bit circular. And in philosophy, Gilbert Ryle classified this as a category error. So it's a bit like saying chairs and tables are both furniture, therefore furniture causes chairs and tables. If you doubt how common this category error stuff is, what I would suggest to do the next time you're at an MDT, as opposed to doing your normal thing, I want you to listen really carefully for misuse of causation and this category error. It is all over the place in CAMS thinking. And to take it into another example, you know, evaluating ADHD on the basis of a series of behavioural symptoms is a bit like in paediatrics for other common symptoms. So let's think of a cough or fever. You know, if you find cough or fever, that you don't classify cough types and then lead directly to diagnosis, but you see the coughs and the fever and you think about further evaluation, what might underlie it. So giving codeine for a cough on the basis of checklists of cough type is a bit like ADHD, because what you would do is you would suppress the cough with the codeine, but it's not curative for most courses and could actually delay diagnosis and real treatment. So this fact that there's this circular definition has been a major driver for research on brain functioning in ADHD. And I can't underestimate how much money and 30 years of research have gone into this question of, are ADHD brains different? And you'll be surprised by the results. So the results overall say there is no evidence that the ADHD brain is clinically abnormal. So number 2 on the quiz is a myth. The debate is about differences, not about abnormality. So it's a bit like, does somebody weigh more than somebody else rather than they are obese? Anatomical, physiological and metabolic brain differences have been extensively researched over 20 years, more than any other child psychiatric problem, and no consistent difference has been identified, and no specific causal mechanism linking brain dysfunction to symptoms have been identified. And you might say, hang on a second, Warren, I went to a CPD with our ADHD clinic and they showed us lots of brain scans, and in the textbooks and on the leaflet produced by the pharmaceutical company it says it's due to brain differences. So I'm going to show you 2 bits of major research, show you the flaws in it, so the next time it's presented to you, you can be aware of how to critique this literature. So, first of all, the problem of the ADHD brain. Sorry, I need to blow my nose. Hang on. Sorry, this is one take recording. So, the problem of the ADHD brain. So, the task of scientists is to compare the brain scans of subjects with ADHD, subjects of controls, and see what the differences are. Sounds simple? Well, the problem is that who are the ADHD subjects that get recruited? Well, they've got to have a diagnosis, and if you're diagnosed, you're likely to be on medication. So that means one group is medicated and one group is not. And there's some evidence from animal studies that use of stimulants can impact on brain structural development. In fact, it's been argued that on studies where they've compared medicated children with normal controls, the brain differences could actually be to do with the impact of medication rather than something called the ADHD brain. But let's get into some studies. So this is from quite a while ago, but I think it's instructive about the ideology that sits behind these studies. So this is from Castellanos et al. 2002, and according to the National Institute of Mental Health, who put a massive banner across their magazine at the time, that they said this settled prior medication use, because what they found was that they compared medication naive ADHD children with a control group. However, if you look at the three control groups, the three groups, there was 49 unmedicated patients, 103 medicated patients, and 139 controls. So this evidence is based on 49 kids. So what did they find? That the brains of ADHD children are 3% smaller than controls. And the National Institute of Mental Health went, job done. And I cannot tell you the number of books that quote this research even today. However, when a reanalysis of the original data set was done by Leo and Cohen, they found that the control group was on average 2 years older than the ADHD group. So what this groundbreaking study found was that as children grow older, their brains get bigger. A proposition that I think even the most rabid social constructionist would probably accept. Then we have a more recent study. This is from Hoogman in the Lancet. In fact, this was such a big study, it was referred to as a mega analysis. And it said the results from our studies indicate that people with ADHD have differences in brain structure and therefore a disorder of the brain. So this multi-site mega-analysis, there were 1,700 subjects with ADHD, 1,500 with controls, a mixed number that had medication and no medication. However, here's the crucial bit. Some differences varied across sites. There was a large differences in the nucleus accumbens, that in some sites it was smaller, in some sites it was larger, and in some sites there was no difference. And also what we found was that that sites using different machinery and analytic algorithms ended up with slightly different results, as we can see around the nucleus accumbens. I'm not going to say much about this, but in terms of structural neuroimaging studies using an MRI, this is where sorry, no, I'm getting ahead of myself. So overall, this is a more conclusion about the imaging studies. Findings are inconsistent, with some finding smaller structures in ADHD, others finding asymmetry. So it's hard to form conclusions. However, it's interesting that Singh, who's one of the major researchers in ADHD, talks about structural neuroimaging studies in ADHD research suggest that patients have widespread anatomical differences. This is wrong. It's just that studies have found different differences. It's not that there's widespread anatomical differences. It's that whichever study you go to, they seem to pinpoint a different bit of the brain. What's really interesting is what Whiteley has suggested, that these differences, even if they found them, may relate to the lower IQ of the ADHD group. And obviously in imaging studies, they don't screen for IQ because, as you know, it takes bloody ages to complete a whisk. So it could be that these differences in the ADHD group, if and when they have found them or have found them, could be to do with IQ levels. So overall, the summary of the brain research is somewhere in the brain, a little bit, maybe a little bit smaller in some ADHD, but we're not really sure. Interesting that that's not the picture painted in your average leaflet given out in an ADHD clinic. Also, it's important to realise the medicalisation of difference. Physiological differences does not show that the ADHD group has a disorder. If they found brain differences, it wouldn't mean they had a disorder. For example, there's going to be brain differences between left and right-handers. It doesn't mean that the less dominant group has a disorder. So neuromyths. The real debate is not about brain abnormality, but about minor differences. Often what it ignores is neuroplasticity, or the suggestion, I saw this in The Psychologist, that 6 months of piano practice or learning German can change brain structure. The other bit is that a lot of our neuroimaging research is based on quite new methodologies, and it might obscure the infancy of some of this research and some of the problematic. So 2 years ago, an assumption made in a lot of neuroimaging research methods was shown to be false, and that killed about 500 papers. So keep an eye on it. So ADHD medication, you've got to keep an eye on this marketing of drugs. There is no such thing as ADHD medication. The stimulants that are kind of used. In the same way that there's this lovely phrase, antidepressant, as if it creates the idea that in our mind is a depressant that it acts on. But as we know, serotonin is no more a cause of lack of serotonin is no more a cause of depression than lack of aspirin is a cause of a headache. Again, there's kind of faulty thinking that goes on there. And what we know about methylphenidate stimulant medication is that it does give short-term gains. You know, you'll get the blunting of affect, you'll get a narrowing of focus, constriction of spontaneity, and that applies to the whole population. However, whilst there's short-term gains, the lead on the largest study of the impact of stimulant medication on educational outcomes said that there is mixed evidence about the long-term effects on educational outcomes. So with medication effects, there's a need for specialist assessment and long-term monitoring due to contraindications and side effects. There should be 6 monthly reviews and regular drug holidays. And that's the advice of NICE. You go into your average ADHD clinic, find out if they're getting 6 month reviews. It's probably annual given the demands. And how many of them have drug holidays? You know, ask about that. But we have to monitor adverse drug reactions, because one of the contraindications is heart defects and heart problems. Now, if you've got a mild heart defect or heart problem, it wouldn't necessarily be picked up. And that's why we sometimes get multiple adverse drug reactions. A major one is loss of appetite, weight loss, stunted growth, sleep and mood problems, the effect of increased heart rate and blood pressure. So that's why it's really important when children start medication, it's very closely monitored, and that there's regular reviews and, as I said, drug holidays. However, ADHD medication is recommended in the case of severe ADHD and is safe to use. So number 5 on your quiz is a reality. However, safety is compromised by prescribing over the recommended limits, poor assessment and monitoring, and poor adherence to clinical guidelines. So who here knows what justification a psychiatrist needs for prescribing over the recommended limits? Oh, yes, thank you. A research trial? No, they don't need a research trial to prove it. What they need is to state that there is no other possible treatment. So with ADHD, they might say there's no other possible treatment, sidelining the research that's been done on CBT in ADHD. But let's leave that to one side. And then on the basis there's no other treatment, they can increase it to whatever level they like. And over the years, particularly in private clinics, some in West Sussex actually, I've seen some scarily high levels of prescribing. But I think medication effects might be over exaggerated due to something called care package effects. If you're part of an NHS ADHD service, it's a good service. You will get 6 monthly reviews by your ADHD nurse. But more importantly, when your child struggles at school, you know you can turn to the ADHD nurse and say, please, can you support the school with management? It's hard to underestimate how valuable that can be for parents, how valuable it is to school. ADHD nurses are the true legends of our service. Compared to psychologists, they have heroic caseloads of like 100, 150, and their unwavering support for families and being there at times of crisis, I think, actually increases the outcomes that are often put down to medication. So the long-term effectiveness of medication. So I mentioned Pelham's study. This is the MTA studies, and this was multi-center studies using methylphenidate of 579 kids. It's getting a bit old now, but it is constantly quoted as evidence for the effectiveness of medication in educational outcomes. It's quite a complicated data set with follow-up over 40 months and then a further kind of 10 months, but there was 3 groups to get your head around. There was the medication group, there was the medication and behavior group, there was the behavior group and the control groups. Behavior means to parent training behavior therapy. What they found was that reduction in symptoms was greatest for medication and behavioral treatment, then medication treatment, and then behavioural treatment only after 14 months. And this is the study that's often quoted to say, well, clearly medication is better than behavioural only. However, after 24 months, it's really interesting that the 3 groups kind of equalise. So the added benefit of medication seemed to drop away. And what we saw that there's little evidence for improvement in academic or performance or social skills. And this is striking, as the drive for ADHD assessment comes from problems in schools. And here's a quote from, let me find it, yes, here's a quote from Dr. William Pelham. No drug company in its literature mentions the fact that research has not been able to show there's long-term benefits of medication on educational output. However, before you go and start a campaign and get everybody stopped on medication in your ADHD patch, it's not about being pro or anti-medication. It's really not where I'm coming from. It's about scope. What I would say is that there are some kids without stimulant medication and support of an ADHD nurse wouldn't survive in school. And what we know, as soon as kids are out of school, their outcomes shrink. So the argument here is about the scale of prescribing rather than it being good or bad to prescribe. Toxicity. Well, this is the RAIN study from 2010, a long-term follow-up of 3,000 births. It's the world's first independent data on long-term effects of psychostimulant medication, and they had 131 that were followed up on medication, and what they found, a correlation between medication use and long-term cardiovascular damage impacting on diastolic blood pressure over and above the short-term effects. And also in Bouzienne did an interesting study where the 4 months of sorry, let me just I just want to check I'm quoting that correctly. Yes, 4 months of Ritalin use changed brain white matter in children but not in adults. That was quite a small scale study, needs some follow-up, but we need to be cautious about the toxicity of stimulant medication. So let's go on to genetic evidence. So there's been twin studies to show a greater level of symptoms in monozygotic compared to dizygotic twins, widely quoted by Berkeley and colleagues. However, this methodology is rather suspect, and there's been other studies that have shown that sorry, let me start that again. So these studies are problematic because, as we know, monozygotic twins have more similar environments to dizygotic twins, and it could be the more similar environments that drive what is seen as heredity rather than gene pool. However, these twin methodologies of twin studies have largely been rejected and have been shown to suggest the heritability of loneliness, frequency of orgasm in women, and breakfast eating patterns. However, genetics research has moved on to do molecular genetics. This is where they look at similarities in genomic scans in a target population. And following some research by Thapar, we had some major headlines. It's quite a while ago, 2010, but in the Telegraph said ADHD caused by genetic faults, and the Daily Mail said ADHD, genes to blame, not parent. Obviously, Daily Mail really pleased it's got someone to blame, even if it is just organic matter. But when we step away from the hype, what Thapar actually found was a common linkage in 51 out of 336 children with ADHD. So it wasn't all the children with ADHD, it was a small minority. However, in terms of clinical genetics, and you know, Thapar is a researcher of international renown, it is a significant result and therefore a risk factor. What was also interesting in this study was that a number of the control group also had this linkage. So we haven't found the genetic basis of ADHD. What we've shown is that the ADHD group is heterogeneous, and one small group within that may have some common linkages, which may be related to other kinds of difficulties. So question number 4, ADHD runs in families. Yes, it does. It's been shown to run in families, but may relate to common environmental and social adversities, so as much as genetic inheritance. The evidence is uncertain, and as we know from epidemiological studies, families in receipt of benefits or poor family functioning are more likely to have a child diagnosable with ADHD. So in terms of therapy for parents and children, NICE no longer directly recommend kind of parent training, although they do recommend before people have ADHD assessment that at-risk families engage in Webster Stratton or triple Ps or other behavioural forms of behaviour management. However, the NICE guidance does recommend CBT for a narrow group, and it's a problem-solving type of CBT, but nevertheless it is there. Therefore, number 6 was a myth. Yeah, so there we have it. NICE guidance 2015 questioned the efficacy of parenting interventions. And one problem with parenting interventions and parents coming to parenting groups is that UK parents have the longest working hours, and so attending during clinical times is often kind of challenging. And the other issue is that we often exclude fathers as well. But, you know, really need to think about therapeutic support for the whole family in terms of responding to ADHD. So I'm about to finish this talk. So what I'd like you to do is redo the quiz. And, you know, if you want to answer those questions there, you can do, but I'm going to stop because this has gone on too long.